Thanks very much, Fiona, for sharing that and starting the evening for us. I think it really kind of sets the scene for what we're going to talk about just now. And if you just bear with me, I will hopefully share my screen. But what we're going to talk to you about, myself and Dr. Cassie, is a research project that was funded by Brittle Bone Society. And I don't think we've had the opportunity to share it with members of the society. We shared it at the scientific conference that took place in Dundee just last year, but I think this will be the first time that we've been able to share it with Brittle Bone Society members. So we're really excited about that. Heather, is that showing as we would hope it to?
Yeah, it looks good.
Great, thank you. So I'm going to do the first couple of slides, and then Dr. Cassie's going to come in and do the middle part, and then I'm going to talk a little bit again at the end. So, as I said, this is was a Brittle Bone Society funded project, and our project is called Improving Oral Health Care Pathways for People with Osteogenesis Imperfecta. And I think, as I said, with Fiona's description of her experience of the services and that of her family as well, this was something that was really driving the reasons for this research. But just a little bit of kind of background. I'm sure you're all familiar with this. We're not going to dwell on it for too long, but that osteogenesis imperfecta and dental care, we know from previously published research that up to 70% of people living with OI have dental health concerns. And Fiona, you've shared some of that lived experience yourself. And some of the most prevalent anomalies that tend to show up are dentogenesis imperfecta, so that chipping of the teeth and the weakness in the teeth that was described, pulp obliteration, where the nerve of the tooth is replaced by hard tissue over time, and dental impaction, so teeth are stopped in their growth path. Um, and it's something, dental care for rare metabolic bone disorders has been identified as a research topic in the top 10 over the past while. And that was something that drew our attention to this space as well, and really thought that, right, we should be in there in amongst that, trying to do research on this topic. But ultimately, we know that from all of that background literature, we know that people with OI are a group of people who are in need of regular, easily accessible dental services. But we know that there is concern about significant barriers to accessing that care, and Fiona's story demonstrates that perfectly. So the aim of the question we had was, well, how can we improve dental care pathways for people with OI? And we had some specific objectives for the research. We wanted to explore in a little bit more depth, well, what tools and resources currently exist to support people with OI. We wanted to identify in more detail and really pin down what are the barriers to good care or access to care, but what are the enablers? How can we learn from good practice that may be out there and share that more widely? And from all of that, we wanted to be able to identify potential interventions that would address the barriers that we found from our exploration. So from that, we developed some methods. Our research had 4 phases to it. The first one, looking at the literature, as I said, and phase two, patient and public involvement from the very start of this work was really important, that we had the lived experience voice right through the middle of this research, in the design of the research in particular, helping us identify, well, what are the important questions that we need to ask of the profession, ask of the dental kind of cohort in terms of what's important to people with OI. That took us into semi-structured interviews, which we did with people with lived experience and dental care professionals. And phase four is when we developed our recommendations for intervention components, so those things that would help change the experience that people are having with accessing dental care. So first of all, I'm going to just make this a bit smaller so I can see everything. And the literature, as I said, was exploring what was already there. I'm not going to dwell on this for too long because there wasn't an awful lot that we found. And I think Fiona's experience of what she's describing there, with perhaps talking to an orthodontist and they're looking for perhaps a more evidence-based approach to that treatment plan. If you do this, what will the outcome be? Our experience was that the evidence base is not there to support those types of conversations to happen, and for clinicians to say with the utmost, evidence that sits behind it, if we do this, that will happen for you, or there may be a risk of X, Y, Z. So we were disappointed with what we found, or what we didn't find in the literature. We were hoping to come out with something that would provide dentists and patients with more information about the different types of treatments that they may be requiring. So at that point, in our disappointment, we had to take a step back. We took some advice from a clinical guidance group based here in Scotland that they provide national guidance for dentistry. And their advice was to kind of start looking at indirect evidence, review all guidance and guidelines that are out there, and compile a summary of what the best available is. But importantly, was to highlight these evidence gaps and make sure that the dental profession and the research community are aware of this, and call for national dental professional input and further research in this area. So that's what we did, and we published in the British Dental Journal an opinion piece on that, asking for and calling a call to action from the dental community. So I'm going to hand over to Dr. Cassie just now, who's going to talk about phase 2, which is the patient and public involvement focus group.
Brilliant. Thank you, Niall. And I'm going to ask you just to go through the slides for me. So apologies for the next slide, please. Comments. So yeah, as Niall's just obviously highlighted, patient and public involvement in this work was really, really key. And we were really keen to involve patients and the public in it as early as possible in order to help design the research study. If you could move on to the next slide, please, Niall. So the first thing we did was carry out a patient and public involvement focus group. And we followed NIHR methodology, which is the most robust guidance out there in terms of patient and public involvement. And we invited participants from across the whole of the UK to take part in an online focus group, which we conducted using Microsoft's Teams. And we had 13 participants in that focus group who either had lived experience of OI or caring responsibilities for somebody with OI. And the discussion was really around, and Niall kind of presented this at the start, firstly, how do we design this project? Who are the people that we really need to be speaking to? Who are the key stakeholders to involve, particularly in the interview stage? And then what are the important topics that we need to discuss? What are the key questions that we need to address as part of those interviews? And what we found during this focus group was, in addition to being able to address some of these questions and help inform the next stages, people also really wanted to share their stories about accessing dental care and really, share those barriers and enablers that they'd experienced. Next slide, please, Niall. So you can see some of the quotes that came out of that focus group, but what we were able to do was really kind of categorise the key barriers that were presented. And those were around knowledge, but then also financial, physical and emotional barriers. And you can see these quotes, they really kind of highlight feelings such as worry, fear and frustration, and the emotion that was attached with trying to access dental care. And I think what Fiona was saying, really, I was really struck by it, really similar to a lot of the stories we were hearing from the patients that we spoke to. And you can see here, one of the patients told us a story about her dad having to carry her up and down the practice stairs to allow her to access the practice. And also just at the bottom here, one of our participants said they just felt a little bit let down by the normal dental service, which is really disappointing to hear. And I also reflected on Fiona's comments saying, it felt like an uphill struggle. And those were the themes that were coming out of this work. So this allowed us to identify who are the people that we need to speak to, who are the people who are involved in the delivery of care, and what are the questions that we need to be posing to them. And that took us on to the next stage, Niall, if you could move through to the interviews. And that was a semi-structured interview study. So if you could move on to the next slide, that's great. Brilliant. So we carried out interviews both with people with lived experience of OI, but also those involved in the pathway delivering care. So healthcare professionals involved in delivering care to this patient group. We interviewed 11 people with lived experience, just over half of them were female, range of ages, as you can see, and a range of levels of severity of OI as well. And in terms of demographics, just over half said that they were registered with a dentist and they were able to attend regularly. And of those, 6 were NHS and 2 were private. And then in terms of our demographics of our healthcare professionals, as you can see, they had quite a significant amount of experience, an average of around just over 20 years. And we had a range of roles, so quite a number of paediatric consultants, general dental practitioners, hygienists, dental nurses. So quite a few people involved in that delivery of care. And of those, just over half, 7, said they had experience of caring for somebody with OI. Move to the next slide, please, Niall. So again, the key themes that came out of these interviews were actually really similar to what we identified from the patient and public involvement work. They really mirrored the key barriers. So focusing on sharing knowledge and then physical, emotional and financial barriers that were being experienced. And you can see from these quotes, patients really felt that some professionals, particularly those in primary care, were reluctant to treat them due to a lack of knowledge and understanding of their condition. And patients reported being really keen to be able to share their knowledge about their condition as part of a shared decision-making conversation. And again, that kind of coincides with what Fiona was saying about patients know the questions to answer. Once patients are able to have that conversation, know the questions to ask, and start that shared decision-making conversation, people felt that really helped. You can see from the top right quote on this slide, I think it's very useful if you can present as having an understanding of your condition, because it's in your best interest that the dentists do a really good job. Physical barriers also really hampered people's ability to be treated in primary care. And again, you can see from the quote at the bottom, this particular patient felt that they really could be treated in primary care. They didn't believe they merited be referred to specialist care, but they were being referred because they were in a wheelchair and their practice didn't have the facilities in order to see them. So this physical barrier really left them feeling frustrated, adding to the emotional impact that they were feeling, and the patient reported feeling as though they were a burden on the system. So I think it's really clear that feelings of worry, anxiety, were really evident, in terms of what the patients were reporting to us, and they reported feeling embarrassed to go to the dentist despite having done their best to look after their teeth and eat well. So there were some really frustrating and really kind of disappointing stories being presented from the patient group. And when we spoke to the healthcare professionals, Niall, if we can move on to the next slide. Again, interestingly, quite similar themes, although perhaps looking at them from slightly different perspectives. So in terms of financial barriers, again, that was another one that came up. However, the healthcare professionals were identifying more indirect costs to patients. So thinking about things like increased appointments, having to travel more, perhaps more time away from school or work. Whereas the patients were reporting the actual cost of the dental treatment. And that it's possible, we spoke to quite a lot of paediatric dentists, so it's possible that they were less aware of the costs because they were seeing children who weren't incurring costs. However, that was something that was really evident from the patients around the cost, and perhaps feeling as though they're being pushed towards private care in order to be seen. Knowledge was also a significant theme. Professionals were keen for support rather than standardised training. They wanted to be able to go and access support if they knew they were going to be seeing a patient, have some kind of resource that they could go to specifically look for advice, perhaps some kind of network specialist that they could refer to. So they also welcomed the idea of having those shared decision-making conversations with patients, and they liked the idea that patients would come to them with information to help them have those conversations. So really, this is just a very brief overview in terms of all the findings that came out of these interviews. We collected a wealth of data, which was absolutely fantastic, and it's allowed us to really analyse this to develop theory-informed recommendations. And I'm going to pass back to Niall, who will talk you through the process that we've now gone through, having analysed this data in order to make some recommendations. Thank you.
Great, thanks very much, Heather. So as Heather said, we had this wealth of data from a mixture of voices right across the UK. And what we then did was we brought this into a framework, which you can see here on the screen. I'll try my best to make sense of it and describe it. But it provides us with an evidence-based approach, a theory-informed approach to developing our recommendations for intervention components. So all of those conversations that Heather was having and one of our colleagues, Dr. Megan Crichton, was having with the healthcare professionals, having with the people with lived experience, we bring it into this process. Those voices are right there in the heart of that. And it's our job then as the researchers to map those voices through to an underlying theory and model, which is shaped around COM-B. And this is the capability, motivation, or opportunity of a person to do a behavior. And within that space, or within that model, there are a whole raft of elements that we can map through to, including psychological elements. So Heather talked about some knowledge areas that we identified as potential targets or intervention components that require development. But also thinking about what motivation people have, setting intentions, social and professional roles and identity, and exploring these elements through the theoretical domains framework, which is attached to COM-B. So we took it through this process, that qualitative interview side, the interviews, semi-structured interviews, put it into some software, and we do a thematic analysis that comes through that. And then we put it through the behavior change wheel. And this is a little bit about what you see here on the screen. It helps us identify intervention functions. And I think if I look at the education piece, first of all, you can see here at the top, if we were to look within that model, intervention functions that come together might be around education, persuading someone that this is a good thing to do, enabling people, be that with some kind of skill or a tool to do the behavior, restructuring the environment. That might be around thinking about how the dental practice is set up, how dental practitioners are approaching the appointment that the person with OI is attending. And we bring all of this together to identify behavior change techniques. And we've done this for people with OI and for healthcare professionals. And you can see that on the screen. Along the top, the behavior change techniques we've identified in the top right-hand corner are for people with OI. So this gives us almost like an ingredients list for intervention development. So thinking about adding objects to the environment, prompts and cues, where you get your information from needs to be a credible source. Should that be the NHS? Should it be the Brittle Bone Society, for example? And we do the very same for the barriers that we've identified for the healthcare professionals, again, adding objects to the environment, prompts and cues, etc. So this gives you a little bit of a flavour of what we're doing as researchers in the background, trying to make sense of everything that we've heard, use a theory-informed model to design an intervention so that we can say that, yes, what we're putting forward is likely to make a change and to change the things that people are telling us need to change. So let me see. And this is where we've ended up. We have, from that process, produced a range of recommendations that we think would help improve healthcare pathway, the oral healthcare pathway for people with OI. And they're here on the screen. We've come up with 6 recommendations that we've put forward in our report, our research report. And here, the first one that you can see is around developing a dental passport. And I think we've kind of had some conversations recently about the wording of passport. Is that the right term for it? But ultimately, what we're trying to talk about here is some kind of physical resource that a person with OI can have and bring into a dental practice that describes person-specific information about that person with OI. So it may be about how transferring into the chair, there may be a particular way that should be addressed. It may give information about the severity of the OI or the type of OI that person has, but also more specific things about dental anxiety or particular concerns that patient may have, so that the dentist that you're seeing is aware of your specific needs and your specific concerns. Next on the list, we have a recommendation around information pack for dental professionals, because as Dr. Cassie has highlighted, we found that not every dentist is seeing somebody with OI. Only half of the group that we spoke to had seen a dentist, and the average practicing time of that group we spoke to was around 20 years. So it's not often that a dentist will come across somebody with OI. More specialist colleagues who we've got on the call tonight will be seeing people a lot more regularly, but our general dental practitioners on the high street less regularly. So we wanted to put forward a recommendation that there should be a resource for those general dental practitioners that they can call upon as and when they have somebody coming to see them, so that they're up to date with the latest OI information, key oral health messages, which may be bespoke and tailored for this group. Other things that came out of that as well were around ask an expert, contact lists, so that dental professionals could be supported, so that we could try and find a way that care could be delivered perhaps closer to home and less need for heading through to specialist centralized services if that was appropriate and safe. And listening also to what Fiona was saying, this comes through in our recommendations around resources for oral health self-care. And I was delighted to hear that the impact of our students visiting from the University of Dundee to Brittle Bone Society has had, Fiona. But I think it's about tailoring some resources with key oral health messages, tips about toothbrushing and fluoride toothpaste, etc., and some specific things that might be helpful for people with OI to consider. But I think what Fiona is saying as well is tools to help conversations in the dental practice, which is really important. I think that's something for us to reflect on, Heather, as well. Actually, it's quite exciting to hear that. Improved and streamlined referral pathways were key. But I think if I was to do this again, I would be saying that all of these little bits that we're bringing together could help improve that pathway overall. I think our goal is to improve the pathway, but I think it requires multiple components along the line. Another idea was the support group for OI specific to oral health. Now, more recently, we have this list, but of course, we will have finite resources. We want to kind of do something that people think is most important to work on. So we took a bit of a step back and said, well, let's prioritize this list and see what should we work on first or next, or recommend for others to do. So we did a prioritization exercise. We brought a group of dental professionals and people with OI and contacted them and showed them these recommendations that come out of our research. And we used a tool called Appease, whereby we put each recommendation to that group and say, how acceptable do you think it is for a dental passport to be developed or to be used? How practical do you think it is that would be used? Do you think it would be effective? Rating the affordability of doing something like that within a system, any unintended consequences from introducing that type of intervention, and then how equitable it would be to deliver that or to introduce that recommendation. So each of those things that we talked about, we put to the group, and then we did an overall analysis looking at the average responses for each of that and the different scores that were given for these categories within Appease. And what's come out on top are the development of this physical resource, a dental passport of some sort. Perhaps we're not going to call it that, but it's that function is what was identified as important, and the information for dental professionals. And in our most recent conversations with Jasmine, who we're going to hear from later on, is about how we connect those two pieces and that they can support each other. Ultimately, we believe that would help improve and streamline the pathway for people with OI. So that's a summary of our research, and I think what really got us into this as well was the advocacy of Brittle Bone Society, and I think that is something that the society can be really proud about, and that work that is done. Heather and I were inspired by some of the activities that we heard about and initially got involved in, and then applied for the grant funding. So we're absolutely delighted to have been able to deliver on this research, and thanks so much for listening.